Hello, everyone. Welcome to the CAP webinar on anxiety, diagnosis, and treatment. I have the honor of introducing our two guest speakers today. Dr. Lauren Schumacher is a child and adolescent psychiatrist here at one of our consultants with the CAP portal. So you may have spoken to her on the phone at different occasions, and she also helps to organize our CNE programs. And she is also seeing patients clinically on both sides of the bay here with UCSF Benioff Children's Hospitals. We also have Dr. Anna Swan, who is trained as a clinical psychologist, who was also formerly on faculty here at UCSF. And previously before that at New York University. She is now with Lumate Health, helping to direct their clinical programs of providing telehealth cognitive behavioral therapy for anxiety disorders. They will be speaking today on childhood anxiety diagnosis and treatment. With that, I will hand the virtual mic over to our speakers.
Thanks so much for having us. We're really excited to be here. Next slide. So I wanted to start off with some financial disclosures. UCSF CAP is supported by federal and state grant funding, and then I also have reported stock holdings for my position at Lumate Health. Next slide. So we are super excited to be here. We're hoping you're going to come away with an understanding of how to identify and diagnose anxiety disorders in youth, be able to explain cognitive and behavioral treatment strategies to teens, kids, and parents to help address anxiety, and also to be able to describe medication options for treating anxiety in this population. Next slide. So even in the best of times, youth experience a number of stressors. So school is the most common source of stress, and nearly 60% of teens and 40% of children report that managing all of their activities can be a source of stress. So it's understandable that youth are experiencing some anxiety. Next slide. Of course, we are not in the best of times, and in fact, Generation Z is least likely to report very good or excellent mental health compared to other generations. So only 45% of Generation Z were reporting that on this survey in 2018, compared to 70% of boomers. And it makes sense. There are a lot of very stressful things that are happening in our world right now, very upsetting things, from mass shootings to our mental health crisis, rising rates of suicide, climate change, global warming, separation of immigrant and migrant families, widespread harassment reports. And Generation Z is most likely to be impacted by these topics compared to adults overall. Next slide. So even if your blood pressure weren't already rising, as I'm sort of sharing some of these typical stressors that teens and kids are experiencing, here are some other commonly reported ones. Technology, this is really double-edged, where it can be an incredible source of stress, as well as a source of joy and connection. Political issues, a lot of youth have worries about the future, college, jobs, affordable housing, crime, violence, grades, school achievement, and acceptance. Next slide. And so for all of these reasons, even before the pandemic, rates of anxiety were on the rise, and then COVID-19 hit. And 2.6 billion youth were affected across the globe. 1.5 billion were impacted by schools shutting down for extended periods of time. And in a recent meta-analysis of 29 samples across the globe, it was estimated that rates of anxiety and depression doubled compared to our pre-pandemic estimates. And so this is why the U.S. Preventative Task Force is now recommending screening for anxiety starting at age 8 in response to this ongoing youth mental health crisis. And I think if you've been noticing more reports of anxiety and depression in your clinical practice, you are definitely not alone. We're seeing this across the board. Next slide. So we're going to start with, what is anxiety? Anxiety is a human emotion that we all get to experience, and there are 3 components to it. There's the feelings piece. So with anxiety, we're thinking about that fight, flight, freeze response. A lot of those things that happen in your body when you're feeling nervous. Then there's the thinking piece, the cognitive piece. So when we're nervous, usually we're thinking ahead to bad things that might happen so we can plan for it. And then lastly, there's the behavioral piece. When we're nervous, we're signaled that there's some sort of potential threat. And so usually we don't like that feeling of anxiety. And so we try to escape or avoid the situations that make us nervous. And often this can be very healthy, helpful anxiety. So let's take an example. I've got a test coming up and I feel some butterflies in my stomach. And I'm thinking there are some things that I don't know about this test that's about to happen. And that motivates me to maybe ask a friend for some help or review the notes one more time. So that's healthy anxiety. It's manageable, it's reasonable, it's time limited. Next slide. And of course, then we have those times that anxiety becomes a problem. So if we take that same example, maybe this time I'm feeling nauseous, like I'm going to throw up, I can't concentrate, I'm restless, I'm having a hard time sleeping. My thoughts are jumping ahead to, I don't know anything about this test. I'm going to fail. It's going to affect my grades. I'm not going to get into the college that I want. And these are actually thoughts that I hear a lot from kids and teens that I work with who have these school-related worries. And then sort of the behavior might be procrastination, just so overwhelmed. I can't bring myself to study and I miss school the next day because I am so fearful of bombing this test. Or maybe I go the other way. Maybe I over prepare. Maybe I stay up, just making sure I understand every single concept for this worry that I'm going to get a question I don't know the answer to. And I can't spend time with my friends or my family because I'm so worried about my grades. And so here the anxiety has started to become a problem for sure. And we often use this false alarm analogy. So if you can imagine, I'll share this metaphor with families. Imagine in your life, how many times have you heard a car alarm go off? And now imagine in your life, how many times have you seen someone breaking into a car? And for most people, there's a really big discrepancy where for youth with anxiety, their alarm is going off saying that they're in danger far more often and far more intensely than it needs to. And this can lead to a lot of distress and a lot of difficulties. And so when that false alarm is sounding, that's sometimes when youth are starting to meet criteria for an anxiety disorder. And there are 4 Ds that you can keep in mind when you're thinking to yourself, is this elevated anxiety sort of enough to meet criteria for a disorder? So the first D is dysfunction. And in some ways, I think this is one of the more important things to think about. Is the anxiety holding the child or teen back from what they want to do or what they need to do at home? Are they having a lot of arguments because they're so irritable because of their anxiety? Is it interrupting the nighttime routine? At school, are they having negative impacts on their grades because of their anxiety socially? Are they having friend difficulties? Are they having a hard time participating in activities they'd like to do? And when anxiety is causing a problem in at least one or more areas, that suggests, this might be meeting criteria for an anxiety disorder. The second D is distress. So anxiety is an uncomfortable feeling to have. And when it's happening often and the anxiety is sounding loudly, when it's chronic, and can really lead to a lot of significant upset and distress. The third is duration. So how long has this been going on for? We're all about to enter the school year. It's incredibly common for kids, teens, even parents to have some elevated anxiety around transition points that first week or month of school. But when anxiety has been going on for a more prolonged period of time, 6 months or more, that suggests that this isn't going to go away on its own. And then the fourth D is deviation from the developmental trajectory. So is this anxiety above and beyond what we would expect for where the kid is in development? And then also what we'll sometimes see is for a child who's been experiencing anxiety for a while, that can also negatively impact sort of them achieving certain milestones. They might miss out on doing sleepovers or going away to summer camp or trying out for that sports team or extracurricular club, learning how to drive, and eventually sort of being able to launch into adulthood and into independence. Next slide. So here I'm going to share some quick facts about anxiety disorders. They're incredibly common. The most common mental health concern that youth experience, with 3 in 10 meeting criteria for a disorder by age 18. We also know that anxiety disorders often go overlooked. So many times these are not the youth who are having behavioral difficulties at home and at school. This might be the straight A student or that super sweet kid who's just really people pleasing. And so their concerns often don't get picked up. But at the same time, anxiety does cause a lot of interference across multiple domains: academics, social functioning, and family life. We also know that when untreated, anxiety disorders don't tend to go away on their own. In fact, it's the opposite. They typically persist into adulthood. And we can also think of them as kind of a gateway disorder where untreated anxiety can lead to the development of other anxiety disorders, depression, and substance use. And so that's why when a youth is experiencing elevated anxiety, we don't want to take a watch and wait approach, because it's probably just going to lead to more problems later on. So a lot of times you might think about that middle schooler who has some social anxiety, who has some trouble making friends. Then they go into high school. That really sets the stage for some lower mood. And then they start to potentially use substances as a way of unhealthy coping with those negative feelings. And so that's why we're all here, because even though anxiety disorders are incredibly common and have negative impact on the lives of youth, they're also quite treatable. And so primary care is such a fantastic setting to increase both the identification of this often overlooked set of disorders as well as their treatment. Next. So here we have some of the types of anxiety disorders. I'm going to share a bit more about the ones that are in bold on the slide, just to kind of give you a flavor of what to be listening for, what to be looking out for. Here, I mostly want to highlight that with anxiety, comorbidity is the rule rather than the exception. It's incredibly common for youth to meet criteria for more than one anxiety disorder at the same time, or for the sort of flavor of their anxiety to change over development. So you might have a little kid with more separation concerns and specific fears. Then in adolescence, they might develop social anxiety. And then as they're going off and preparing for college, they might have some more worries about that process and some more generalized anxiety concerns. And it's also really common for anxiety to go hand in hand with other concerns like depression and ADHD. Next slide. Okay, so here I'm going to share a little bit more about separation anxiety, what to look out for. And on these slides, I've also included some celebrities who have been open about their experience with these concerns, just to normalize that it's incredibly common and put some famous faces to some of the things that a lot of youth are dealing with. So separation anxiety is characterized by inappropriate anxiety separating from a caregiver. And here, the core fear is something bad is going to happen when the child is separated from their caregiver. So maybe the child is going to be kidnapped, or the parent is going to leave and never come back, or get into a car crash. And we do see this, as you might expect, more often in younger kids. Some of the signs that you might hear about in primary care: a kid who's having a hard time separating at bedtime, if that's within the family norms, having a hard time separating for school or for play dates, other activities. A lot of times we'll see physical symptoms of separation. So you might hear about that in primary care: frequent stomach aches, headaches, reassurance seeking, wanting to call their parents often when they're separated. I've worked with a number of kids who have their parents on Life 360. And it's they're checking to make sure they know where their folks are. We also might see a lot of school absences because of the separation anxiety and visits to the school nurse. Next slide. Generalized anxiety disorder. This is also incredibly common. And the key feature here is worry, excessive, uncontrollable worry, where you really get stuck, usually about everyday life things: school, grades, health, safety, stuff that's going on in the world. Sometimes there's a specific area of worry, maybe school and grades. Other times it's flavor of the day. The worry changes, but this child is always feeling worried about something. We tend to see this more in teens. And the worry also comes along with physical symptoms: feeling restless, more tired, trouble concentrating. So this can be an important differential with ADHD. More irritability, so also an important differential with depression, muscle tension, sleep disturbance. So a lot of times, kids and teens are so busy throughout their day But then when night comes and they finally have a moment to think as they're trying to fall asleep, no distractions, that's really when you see the worries come up more often. It can really make it hard to fall asleep. Some other sort of signs you might hear about, being more perfectionistic about work, doing a lot of reassurance seeking. Am I doing this okay? Is this all right? Just seeming jittery, anxious, always jumping to that worst case scenario. And then difficulty with perceived criticism, sort of being more sensitive to that. Next slide. Social anxiety disorder. Here, the core fear is worries about doing something embarrassing, being laughed at, negative social evaluation, being judged by others in social situations. And there's sort of two main categories. There's performance situations. So, anxiety and avoidance, giving presentations, participating in class, sports performances, musical performances. That's one category. And the other category is less structured social situations, things like meeting new people, going to a party, inviting friends to get together, assertiveness. Sometimes you can have social anxiety just in one of those areas. Often it comes up in both. Again, we see this more often in teens, which makes sense in terms of development. Sometimes youth with social anxiety also have social skills difficulties, especially if this has been around for longer. They might have avoided and missed out on opportunities to build those social skills earlier on, but not always. Sometimes I work with many kids and teens who are incredibly socially skilled, but they still get really stuck in those worry thoughts about what if I said the wrong thing? What if somebody doesn't like me? And so things to look out for are when youth are avoiding different types of social situations, or maybe when they're going, but it's just very distressing for them. You can also see academic difficulties coming along with social anxiety, which makes sense if you're having a hard time asking for help and participating in class, doing group work, that can impact how you're doing in school. And sometimes, as you might expect, there might also be difficulty with friendships, making friends, maintaining friends as a result of the anxiety. Next slide. So I also briefly wanted to talk about OCD, or obsessive compulsive disorder. This is technically no longer an anxiety disorder in the DSM, but they really go together, and how we treat OCD and other anxiety disorders is quite similar, though there are some distinct differences. So with OCD, the youth experiences intrusive thoughts. Classically, you might think about contamination concerns, but really it can be in a number of different categories. These thoughts are experienced as incredibly distressing. And so then the youth engages in some sort of compulsion or behavior to neutralize, to make that thought go away. So again, classically, you might think about hand washing, but it can also be mental rituals like counting or praying and doing things like that. That provides temporary relief, but actually feeds the OCD cycle over time. So an analogy that I'll sometimes use with families is it's kind of like a rash, where the intrusive thought is the itch. And then when you scratch it, that gives that relief. That's like doing the compulsion, but it actually spreads the rash over time. So the behaviors are actually keeping the cycle strong. Some kids and teens have little intrusive thoughts and certain behaviors that they'll do. To meet criteria for OCD, this is really causing significant interference, typically taking, at least an hour a day related to having these thoughts and behaviors. What you'll notice can really vary based on sort of the symptom presentation, but we do see that these compulsions can interfere, make kids get stuck and have a hard time attending and participating in activities of daily living. And you might also notice just a lot of reassurance seeking, checking behaviors, and other rituals. Next slide. Okay, and then I also wanted to talk a little bit about school refusal. This isn't a separate anxiety disorder diagnosis, but I think we are seeing more of this as people are going back to in-person learning. So school refusal, it's more than, just school jitters, just feeling nervous or a little bit down about going to school. These are youth who are having persistent problems with staying in school, missing a lot of days of school. It's important to think through the length of time. Usually the longer the youth has been out of school, the longer it's been going on, the harder it is to treat. And then we also need to think about sort of the function of the school refusal. Why is this happening? And I'll talk about that in a second. School refusal is also different than truancy. These are not kids who are skipping school to, go have fun or do other activities. Typically when they're staying home, missing school, they're pretty miserable at home, feeling pretty bad. And we see this at times of transition. So that transition to kindergarten, that transition to middle school. And again, I think we're all seeing a little bit more of this, again, as we're transitioning back to in-person learning. I'm also going to share just like the bare bones of what we try to do with school refusal. I think one thing to know is when there's a child who is having a hard time attending school, ultimately we want to figure out a way to get that kid back into school, back into learning, back into their social life, because the more that they miss out, the harder it is going to be to sort of get them back on their developmental track. So the first thing that we want to do is figure out, what's the function of the school refusal? Is this a child who is experiencing a lot of anxiety or low mood at school? And so staying home is a way to avoid those negative emotions of school. Is this a kid who is having some teasing at school or a lot of worries about social evaluation? And so staying home is a way to escape from that. We also want to be mindful of any potential inadvertent secondary gain. So for example, you might think about a kid who has separation anxiety, and if they miss school, then they stay home with a parent. And so that extra attention from their parent and the ability to avoid that anxiety of being awake can be incredibly reinforcing. And also we want to think about sort of tangible reinforcers too. So you might have access to certain things when you stay at home, like a bed where you can sleep in or take naps, or screens that you don't have access to at school. So once we have an understanding of sort of what is the function of the school refusal, we want to also think through what it is about school that's causing anxiety, and sort of how do we address that as part of the plan. Again, we want to understand what happens when the kid stays home, and as much as possible, we want home to look like school. So if there's no access to screens at school, there's no access to screens at home. And then we also have to think about sort of these physical symptoms that can often come up that we've been talking about that go along with anxiety, like headaches and stomach aches. And we might respond to them differently for a youth who's experiencing anxiety than for a youth who has the stomach flu, where we really would say, oh, of course, you're feeling sick, stay home. But if these symptoms are stemming from that anxiety, we're really going to try to figure out a plan to encourage attendance. And then ultimately, it's incredible. It can be really hard to treat school refusal. So requires a lot of patience. It requires a huge team effort. This is the family working together with the school, working together with the whole care team to come up with a flexible, effective plan to get the child back to school. Next slide.
So when a kid or teen comes and visits you in your office, you often may have a sense of this seems like an anxious kid. There's kind of that gestalt feeling. It can be often hard to sort out kind of which of these anxiety disorders may be going on. So assessment tools can be really helpful for that, to get kind of additional data. The SCARED is especially helpful for sorting through some of these different types of anxiety. It's research validated for ages 8 to 18, but clinically we'll sometimes use it even a little bit younger than that, especially if an adult can kind of go through the questions with them. A nice thing about the SCARED is it has both a parent report and a self-report, so you can get both perspectives. And then it gives you a sense of kind of overall level of anxiety, as well as kind of specific concerns about generalized separation, panic, and social anxiety as well, and school avoidance. The downside is it's long, it's 41 items, so it does take some more time to fill out. So it can be helpful to either while you're talking with the youth, have the parent fill it out and vice versa, or give it to them to take home and bring back at the next appointment. The GAD-7 is also one we commonly use. That one's research validated for 13 and up, but we also will sometimes use it for a little bit younger than that. This one just has a self-report, but can give you a sense of kind of the anxiety symptoms, especially those generalized anxiety symptoms that a youth is experiencing. And a nice thing about the GAD-7 is that it's just 7 questions, so it's a lot faster to complete. And both of these can be helpful kind of when you're first kind of evaluating for anxiety to give you a sense of the baseline and help you make the diagnosis. And they both can also be used to kind of track response to treatment over time and kind of track whether anxiety is getting worse or better. I would say that the GAD-7 with being shorter is especially useful for that tracking over time. And these are available on the CAP website. Next slide. So you've heard a lot about anxiety disorders being on the rise and all these different stressors that our youth are dealing with. But the good news is there are effective treatments. ACAP practice parameters recommend that for anxiety disorders, you should take a multimodal approach, including education of parents and youth about anxiety disorders, consultation with the school, therapy, and medication. Next slide. So to start with, in terms of education, it's helpful to kind of share some of what you heard about anxiety that Dr. Swan talked about at the beginning, like the idea of kind of the car alarm that's going off too frequently and that false alarm. There's also a lot of really helpful online resources, both things for parents and youth to read about. On the CAP website, we have both provider and patient family resources. There's also some online programs that kind of give CBT classes for parents and youth on helping manage anxiety. That can be really helpful. I kind of share a lot of these resources with all the families I work with, but I think there's two groups that I think it's especially helpful to emphasize them with. One, as pediatricians, you guys are in an especially good place to kind of have a preventative role and kind of provide some education for those kids and families that you're seeing some anxiety, but they're not at the point yet where they're meeting a full anxiety disorder, maybe experiencing some anxiety. It's maybe sometimes causing distress, but not kind of causing the dysfunction we see with disorders. Since anxiety is something we all experience, it can be helpful to share some of these resources and really help encourage kids and families to kind of learn more about coping with anxiety to hopefully help prevent them from developing an anxiety disorder. And the other place I especially emphasize these is when the family is having a lot of trouble finding a therapist, because we know even when we know we want them to get into CBT, it can take a long time. And next slide. Using these online resources, and there's also some great books for parents and then also kids, next slide, that talk about managing anxiety and things like what to do when you worry too much is actually like a workbook for kids that goes through CBT strategies for managing anxiety. So those can be a great resource while they're waiting to get into therapy. Next slide.
Okay, so I'm going to share a little bit more and hopefully demystify, what is cognitive behavioral therapy for anxiety. So there are a few features to it. It's a goal-oriented, skills-based treatment. So we want youth and their families to come away with skills for how to manage and cope with anxiety effectively. It's also time limited. So we often say, I want to put myself out of business. I want kids and their families to be able to go on and be their own therapist, get back to their lives and not need to come in for weekly therapy. And then another key piece is there's practices that happen in session, but then there are also practices that need to happen outside of session, homework. So that's a key piece of CBT as well. And CBT for anxiety teaches skills at each corner of that CBT triangle that we've been talking about. So to address sort of the feelings piece of anxiety, we'll teach emotion regulation skills, even being able to identify and say out loud, I'm feeling anxious, I'm feeling nervous, I'm feeling scared. That can be regulatory in and of itself. Sometimes we'll teach relaxation skills, although it seems like that's a little bit less important. We'll also teach distress tolerance skills. So how can you sort of ride the wave through an anxious moment and get through to the other side? This might be doing some paced breathing. Sometimes I'll call this box breathing. You breathe in, you hold, you breathe out, you hold. Sometimes a temperature change like an ice pack can be helpful, doing muscle tensing and relaxing one by one. There are a lot of great apps out there as well that can sort of walk you through some of these strategies. To address the cognitive piece, that tendency for anxiety to make us think ahead to bad things that might happen, we practice different skills to help you have a different relationship with their thoughts. And I'll give an example of that later on. And then to address the behavioral piece, really what we're working with youth and families to do is to practice facing fears in session and between session. And so sometimes we'll teach them problem solving skills, how you take this big scary thing and break it down into smaller steps you can start approaching. And then the main ingredient for CBT for anxiety, that's why it's in green, is doing something that's called exposure that I'll also share a little bit more on later. Next slide. So I wanted to talk a bit about the C in cognitive behavioral therapy. So we know that anxiety does two things really well. It makes us believe that bad things are more likely to happen than they are, sort of those what if thoughts. Even if there's a 1% chance of something happening, anxiety is going to make us focus on it and think that it's quite likely. And then it also makes us doubt our own abilities. It makes us think that whatever might happen, we're not going to be able to handle it. And so some of the sort of cognitive practice, skills practice that we're doing is helping youth to have a different relationship with their thoughts and get unstuck from that thinking. So for example, I've got that test coming up. I think I'm going to fail. One strategy might be to ask some questions to examine the evidence for and against that thought being true. What's the evidence that I have that I'm going to fail the test? What's the evidence against it? What's the worst case? How would I handle it? What usually happens? So that's sort of one set of questions. We might also ask questions around sort of the usefulness of this thought. How helpful or useful is it to me to be thinking that I'm going to fail this test? What would my life look like if I didn't believe this thought? I mean, that would be so freeing. I would be able to actually get started with studying and be able to enjoy my time with family and friends without all of these worries. And then sort of another set of questions that we might ask is around perspective taking. So trying to shift that focus away. What would I tell a friend in this situation? In 10 years, how much will this matter? I mean, if I fail and it bombs my future, it would matter a lot, but probably this test is not going to be what I remember about high school. What happens when I say this thought out loud or write it down? What advice would I tell myself later? So you sort of use these questions with the youth. You help them identify what are questions that are useful for themselves to ask themselves when they're feeling nervous. And then your goal is to sort of come away with what's a more helpful way of thinking about the situation that kind of shrinks the anxiety down and makes it easier to approach. Next slide. And then we have the B in cognitive behavioral therapy, focusing on the behavior piece. And like I mentioned with CBT for anxiety, the real key ingredient is doing exposure work. And this is because we know that there are a lot of things that cause anxiety, a lot of valid reasons. Youth are feeling anxious, and avoidance is what maintains it. So I get invited to a party, I feel really anxious about it. I decide I'm not going to go, it's fine. There'll be parties later. That ultimately makes me feel so much better in the moment. But I miss out on the opportunity to learn how to manage that anxiety going there, or to maybe have a different experience than what I was worried about might happen. And so exposure therapy is really aiming to stop this anxiety cycle by collaboratively with the youth, with their families, coming up with a step-by-step plan of how can we actually practice feeling nervous. It's almost like you're lifting anxiety weights, and you might start with a lower weight, doing things that are anxiety provoking, but not super anxiety provoking. And then you get stronger and stronger, build up that muscle, and you can start doing harder and harder things that seemed impossible before. Another example that another metaphor I'll sometimes use is it's a bit like a vaccine. If you have a family where that would be a helpful metaphor for them, where you're getting sort of like a dose of the anxiety in these exposure practices, these brave challenges. And then that makes it so that when you encounter these fears, these anxieties in your daily life, they're less overwhelming. You know what to do to handle them. Next slide. Parents are also incredibly important in treatment with youth, and they can play a really key role in helping their child face fears rather than avoid. There are two super understandable, very common parenting reactions to a child who's exhibiting anxiety. One is for this to be kind of like a frustrating experience for the parent and for them to be a bit more dismissive. It's no big deal, just do it already. You used to do this just fine, come on. And then the other reaction is for this to be a really distressing experience, to sort of see your child upset. There's that very natural instinct to swoop in, to protect, to remove whatever is causing this upset in your kid. And so both of those can actually make it harder for the youth to practice sort of these skills around engaging in situations instead of avoiding when they're nervous. And so here are some kind of tips for what parents can do instead. Spells out care. The C stands for being a coping model. So kids can learn a lot from what they see their parents doing. And so caregivers can model, how they themselves identify when they're feeling nervous or anxious, how they themselves cope in a healthy way with that anxiety, how they're flexible and try things out even when they're nervous. This is different from being an expert model, a parent who just breezes through life, never experiencing any anxiety. That's not going to be super relatable for a kid who's experiencing a lot of anxiety. So really like parents showing through their own actions how to cope is super, super helpful. The A stands for accommodate less. This can be kind of confusing because a lot of times we think about accommodations as really great things. We put accommodations in school to help kids access their learning. But there's a lot of research in the anxiety world that accommodation, which is defined as when the family, when the school, when anyone in the environment helps the child to avoid a situation or escape from a situation when they're nervous, that accommodation actually leads to more severe anxiety and can make it harder. Of course, if you have a really, really anxious kid who's been dealing with this for a while, there are probably a lot of accommodations that are in place. And so you can't just get rid of them all at once. But the goal is to sort of, if you're putting an accommodation in place, to make sure that it's helping the child take a step toward facing their fears, as opposed to removing them from the situation, helping them avoid or escape. So you might think that, again, I'm feeling nervous about that test. I want to miss school. A parent might say, it's fine. I'll write you a school note. You can just stay home, get some rest, and you'll feel more prepared for it the next day. Super understandable response. But what this actually does is it tells the teen, you really do need to study more, or, you might fail. And also you couldn't really handle going to school when you were feeling that nervous. That's why we had to come in. So instead, we really want to be encouraging approach. So, okay, let's think about a way that we could get you to school in a way that feels manageable. Maybe you do, message the teacher and ask for an extension. I'll sit with you if you want me to while you do that. The R stands for reward brave behavior. This is one of my favorites. It's incredibly hard to face fears, and so being able to use praise, other reinforcers. And then the E is empathize and normalize. So telling a kid not to feel nervous when they do, getting frustrated and punitive tends to backfire, just makes anybody feel more nervous. So instead, really getting on the child's level, empathizing, normalizing that a lot of people feel nervous in situations like this. It's okay to feel nervous. It's a safe feeling. It's a temporary feeling, sort of to empathize and also encourage. Next slide.
So the next piece you want to think about in terms of treatment of anxiety is medications. And there's a number of different things that might kind of lead you to be thinking about that as part of their youth's treatment. One is if they're already kind of been receiving therapy, but they're having limited improvement, persistent anxiety despite being treated with therapy. Another is if the anxiety is particularly severe, such as a GAD-7 over 16, that's a time to think about kind of starting medication and therapy together. You also want to think about it if the anxiety is so severe that it's really interfering with their ability to engage in therapy, if they're so anxious that they're not even able to start doing exposures. If they have a comorbid disorder such as depression that's requiring treatment, if, despite efforts that therapy is really just not a treatment that families or the patient are able to access, and if the patient and family prefer to start with medication treatment. And it's helpful to keep in mind that really combined treatment with CBT and an SSRI is the most effective treatment we have for anxiety. Next slide. And a lot of this information comes from the CAM study, which was an NIMH funded study that looked at 7 to 17-year-olds with a number of different anxiety disorders that were randomized to 12 weeks of 4 different treatments. There was treatment with CBT alone, SSRI alone, specifically sertraline, combined treatment, and then the placebo. Next slide. And they found that any of the therapies, so medication alone with sertraline, the cognitive behavioral therapy alone, and combined treatment all had significant improvements compared to placebo, but that the combined treatment was also had significant improvements compared to medication only and CBT only. So while kind of all three approaches significantly helped with anxiety symptoms, the combined treatment was the most powerful one. Next slide. And interestingly, they've done kind of long-term follow-up of the CAMS study and kind of looked in kind of 4 to 12 years after the initial CAMS trial and kind of looked at their remission status over a 4-year period. And next slide. And they found that really their initial randomized treatment of 12 weeks didn't predict remission status many years later. And that kind of the whole group, about 22% were consistently in remission over the 4 years. About 48% were relapsers, so had times where they were in remission and times where they were more symptomatic, and about 30% that were chronically ill. And that, didn't really see significant difference in remission status based on their initial treatment. There were some predictors of remission, and some of these were having an early response to treatment. Patients who were male, had a younger age of treatment, better family functioning, fewer negative life events, and no social phobia were more likely to be in that remission group. And I think that especially it's helpful to keep in mind that kind of that early response and younger age with treatment, because those are two of the ones that we can influence the most. Next slide. So if you're at the point you're seeing a patient and their anxiety is severe enough that you're thinking about recommending both CBT and anxiety, or maybe they've had some CBT but are still struggling and you're wanting to think about starting medication. Our first line medication treatment are the SSRIs, and in particular, we think about sertraline, fluoxetine, and escitalopram for treatment of youth anxiety. Now, I think it's helpful to keep in mind that we actually, none of these have FDA approval for treatment of anxiety disorders per se in youth, but they do have FDA approval for either MDD or OCD. So kind of they're well established as medications that we use in youth, and they are the ones that we have the most evidence for treating anxiety disorders as well. You can refer to the table for kind of starting doses and titration over time. And a common question that comes up is which one to start with. So generally speaking, it can sometimes be helpful to find out from the family if anyone else has taken SSRI. If so, and it's been particularly helpful or unhelpful issues with side effects, that can kind of guide an initial choice. If anxiety is really the most prominent part of their presentation, I'll often start with sertraline. That's the medication that was used in the CAMS trial and tends to be pretty well tolerated. Fluoxetine can be a little bit more activating. So if it's mostly just anxiety, that can be sometimes a less good fit, but it can be an especially good option where there's both significant anxiety and a lot of depression, some more maybe challenges with that kind of low energy, low motivation piece we see with the depression as well. It's also got the longest half-life and the least likely to cause discontinuation symptoms, so it can be a good option if you're concerned about consistent adherence. And escitalopram is another good option. It tends to be well tolerated, also has the fewer drug-drug interactions, so it can be a good option if you have a patient who's anxiety and also is taking other medications. And they're overall effective and have a number needed to treat of about 3 for anxiety. Next slide. So you've kind of chosen your SSRI. You want to start at a low dose and then kind of check in every 2 to 4 weeks as you're starting the treatment and adjusting the dose. If they're having a good response to it, you continue at that minimal effective dose and then think about gradually tapering after they've been in remission for about a year. If they have a partial benefit, want to increase the dose. If there's really been no improvement so far, keep optimizing the dose. until, if they're at the max dose and still not really having benefit, think about switching to a second SSRI. If they're having significant side effects, then you want to think about switching to a SSRI again. And kind of we generally recommend trials of 2 different SSRIs, and making sure to kind of keep pushing up the dose if they're not responding, because sometimes that that's one of the things we sometimes see, is that they may have been kind of probably, if we've got an anxious child, there may also be an anxious parent who's been hesitant about increasing the medication. They're maybe not noticing much benefit from the medication, but they've been so anxious about the medication that it's still at a really low dose, really encouraging to keep going up if they're doing okay with it. And then at that point, if you've kind of had good trials of 2 different SSRIs, you want to be, as always, kind of checking in on your diagnosis. Are there other things going on? If they're not in therapy, can we add the therapy piece or re-engage them with therapy? It's also a good time to think about calling CAP or consulting psychiatry. Next slide. And then one of the challenges with SSRIs is that we tend to see the side effects first, and then the benefit tends to come a little bit later. So they can see some benefit in the first couple of weeks, but we tend to not see the full benefit until 4 to 6 weeks. And often they have to kind of get through the side effects to get to the benefit, which is really hard for all people. And then especially for kids and teens to kind of have that wait through that. But some things that can help: if they're having GI discomfort, it can be helpful to have them take it with food, and kind of, that is something that should get better as their body gets used to it. Sometimes they may also notice headache, making sure they're staying well hydrated, and kind of just can do something like ibuprofen or acetaminophen as needed to help those symptoms until their kind of body gets used to it. If there's sleep problems, sometimes adjusting the dose can help. For some people, it can make them more tired, so having them take it at night can help. If it's making them harder to sleep, maybe some insomnia, having them take it in the morning time can help. It's also good to have a sense of their sleep at baseline, because we know anxiety itself can really impair sleep. So you want to make sure it's possible their sleep might improve as you're treating that anxiety. And then the last piece is sometimes people might notice some restlessness, and when they first start taking SSRIs, they might feel more restless or energized or irritable. If it's not severe, you can kind of encourage them to wait it out and see if that gets better. If it's more severe, you can stop the medication, or if there's any concerns for mania, you'd want to stop the medication and consult psychiatry. And there you'd be looking for kind of more bigger changes in behavior. You'd be looking for disruptions in sleep, things like that. Next slide. A common question that comes up is how to talk about the black box warning. And this, as you guys probably know, there's the FDA black box warning of potential for increase in suicidal thoughts with starting SSRIs in youth. And this was based on a analysis of 23 randomized controlled trials, which found a slight increase in suicidal ideation. In these studies, the primary diagnosis was depression. So this is something we're especially concerned about more for when we're using SSRIs to treat depression, less so with anxiety, but still something we want to warn patients and families about. And it's helpful to kind of keep in mind, we didn't see any increased risk of suicide, so no increased risk of the behavior. And it tended to be particularly at the beginning of medication treatment or during dose changes. And, this is something that really, despite this concern, it's very rare. And we really see that the benefits of treating anxiety and depression with SSRIs outweighs that risk. Next slide. And then kind of after treatment of 2 SSRIs, the kind of next line of treatment are the SNRIs like duloxetine or venlafaxine. And then there's some other medications that we'll sometimes use for treatment of anxiety, either on their own or kind of in augmentation with an SSRI like buspirone, mirtazapine, and hydroxyzine. There's really not great data for these, but clinically they can sometimes be helpful. We really rarely use tricyclic antidepressants because they have a worse side effect profile and need for cardiac monitoring. And then sometimes there are questions about kind of benzodiazepines for use for anxiety. And there really haven't been good controlled trials in childhood anxiety disorders. So it's not something we recommend for children or youth, especially given the risk of dependency and for possibly sedation or cognitive impairment. So we try to avoid use of those. All right, next slide. So that's our whirlwind tour of the different treatments for anxiety. And now we'll open it up to
some questions and answers. And so there was a request to take the slides back to the resources page. So why don't we do that while we bring up the first questions. And the first ones really had to do with how quick, some specific advice on titrating sertraline in particular. So how rapidly can you titrate the doses up? And the example here was if you're starting sertraline in a 14-year-old and you're starting at 25, how quickly can you then go up to 50 and then maybe even up to 100? Or would you stop at 75 milligrams on the way, right? For your typical size 14-year-old.
Yeah, so part of it, I think, is the question of like how quickly to do it. Partially depends on if you're at a point of the dose of, are you kind of at a low dose that you're just starting and kind of seeing that they're tolerating it? And like, is the main question, are you tolerating this okay before we go up? Or are you at kind of a therapeutic dose, and is the question, are you benefiting from this? Is this like a good enough dose to treat you before we increase? So with sertraline, kind of generally, the therapeutic range is kind of between 75 to 200. So while we often start at 25, I kind of pretty quickly try to get them up to generally like around 100, so that you can increase kind of go from 25 to 50 kind of every 1 to 2 weeks, making sure they're tolerating it okay. And then once you're at kind of 75, 100, then I like to stay there for a month, because the question then is, one, I'm still wanting to make sure they're tolerating okay, but I'm also seeing like, is this, we're now at a kind of therapeutic dose. Are you responding to this? And then kind of after a month to 6 weeks, if they're doing much better, we'd stay there. If it seems like they're not getting much benefit or only partial benefit, then increasing more.
So you would increase to 200 before deciding that it's time for a different SSRI.
Yes. So generally it would go to 200 before, kind of 200 kind of for 4 to 6 weeks before I would switch to a different one, unless the reason to switch is that there's issues with side effects. If there's issues with side effects, then would switch sooner.
Okay, wonderful. And one more question on the sertraline. For the younger kids, would you max out at 200 still? Like those who are, okay, so it really doesn't matter in terms of the age.
Yeah, I would, so especially with the little kids, I'll start with a lower dose. So I might start with 12.5 rather than 25. And sertraline's nice. There's the pill, but there's also a liquid form that you can use. So I might start lower, and I'd probably at that with younger kids might go up a little slower. But if they're tolerating it well and they're not having issues with side effects, then I do continue increasing the dose until we get a good response for the anxiety.
Fantastic. We did have a request to show the next resources slide, including the books recommended for the children, maybe for the families as well. I think people were wanting to see that also. Fantastic. Thank you. So next question is, has telehealth been useful for assessment, CBT, and med management for kids and adolescents?
I can speak to the assessment and CBT piece. I would say yes, incredibly. Of all the things that I did in the pandemic, I never thought I would do. Tele worked particularly well for anxiety treatment, particularly for teens. I think if you have a younger kid, potentially has some co-occurring attention difficulties, it might be a harder match. But for a child or a teen who can focus well and use tele well, there are a lot of benefits, because we can actually do the exposure work in the setting where the anxiety is coming up, whether that's at home or at school. And for assessment too, I would say it's very easy over tele. And I'll let Dr. Schumacher speak to.
Yeah, I would say I think it's also something that's been helpful for kind of med management with kids and teens. I agree, probably especially with teens, it's helpful. but with kids too. And then, some of the online resources, like on the prior page, some of those are also like there's one that's a kind of 1 hour free parent session that they have kind of studied as well and did see improvements in anxiety symptoms. And that's kind of like I think like a recorded session. It's not something where you're kind of meeting with someone. So some of those resources can be helpful too.
And websites like Calm or some of these apps that are out there.
Yeah, I would say that those can be really helpful adjunctive treatments. I think if it's a child who's meeting criteria for an anxiety disorder, I feel like at that point, having a therapist, if possible, would be fantastic. Some other ones that I really like are Mind Shift. That's great for anxiety. And then there's also a cool one, Be Me, that's specifically for teens. I'm sure a ton more.
Another medication question here. Can you please discuss using other medications, such as propranolol, as a bridge when starting or titrating of an SSRI for anxiety, or even clonazepam? So, any thoughts about using adjunctive medications like these?
Yeah. So in terms of propranolol, that's one where we have a lot more, or not a lot data anyway, but more data in adults for its use in anxiety compared to youth. So, I think the SSRIs we do tend to go to first. But I think especially in kind of older teens, if there's pretty severe anxiety, that is something you could kind of think about as a bridge if you don't feel like they're going to be able to kind of, I think the question is like, how are they doing? Are they going to kind of be able to keep functioning while we're working on getting the SSRI set up? And so I think it's reasonable in that case, especially with kind of older teens. And, we think of that, if you think back to the CBT triangle of anxiety, the propranolol is especially targeting that feeling part of kind of that overactive flight or fight response. So it can be helpful if, especially if there's like more kind of panic or performance anxiety, where that's a piece. I really don't recommend using Klonopin because I think that it's something where there's just not great data for it, and we have significant concerns about the side effects. So I try to avoid that. I think there are specific situations, like if they're having pretty severe, especially older teens, pretty severe panic attacks that are really disrupting their life or leading to multiple ER visits. I think there's a place to think about it, but definitely want to be very cautious and kind of have a plan, making sure everyone knows it's short term and kind of having a plan in place for how to stop it as well.
Wonderful. Well, it looks like there are no more questions for here. I just want to point out the QR code. Please do scan the QR code. And I believe that if we can also place the URL into the chat so that folks can check in to get CME credit for today. So let's take a minute to do that right now. Want to say a huge thanks to our speakers, Dr. Anna Swan and Lauren Schumacher, for this great talk on anxiety today. Next month, on September 14th, we will have a talk on depression, diagnosis, and treatment. And you can see our speakers there, Dr. Farah Varani, as well as Michelle Ritter. And we hope to see you then. Thank you so much.